Okay, so I'm going to do a few cases of neurological cases of Lyme, but before I just go back over that, Lyme is the bacteria we always think about in terms of causing neuroborreliosis. In America, it affects the joints more. It also affects the brain. In Europe, the strains of Lyme affect the brain more, less so the joints, but it can affect both. And there's other bacteria that also affect the brain. Babesiosis is one of those. And there's a whole bunch of other infections. Bartonella can affect the brain. And there's a number of other infections. Powassan virus is a virus that actually infected a lady called, a congresswoman in North Carolina. She became infected from a tick bite and actually got a neurological disease and eventually died. And so there's actually funding available from the US government in support of Lyme disease based on the death of a politician in America who got bitten by a tick and died of a neurological disease caused by a virus, Powassan virus. And finally, in Eastern European, there's kind of a tick-borne encephalitis. There's a vaccine for that. It's common in Ukraine, Russia, Sweden, and there's now cases in the UK of neurological damage from a tick-borne virus called tick-borne encephalitis. So lots of different diseases. We're going to focus on Lyme today, but lots of different tick-borne infections affect the brain. And then, like I said, if you don't treat it or if you miss it, 10% of people get neurological manifestations, early manifestations, but there's also long-term manifestations that are poorly understood. And some people think that Lyme spontaneously disappears if you don't treat it, but syphilis doesn't spontaneously disappear, so I don't know why Lyme does. And the longer it's in your system, I think the more chronic the manifestations become. And they can persist for months and years if they're not initially detected. And the issue is that it's not just an infectious disease, it's an autoimmune inflammatory disease, and there's lots of data to support that. I just would like to then, before presenting the cases, just to discuss some of the neuroimaging that's been done. Most of the CT scans and MRI scans we do in patients are normal, but actually in the Johns Hopkins experience, they've actually looked at PTLDS, post-treatment Lyme disease syndrome. This is people who get treated and they're still unwell. It's very deceiving. Post-treatment doesn't mean post-infectious, but that's what people now say. You've had your 3 weeks of antibiotics, you're still sick, therefore we can't give you more because the guidelines say this. You're cured, but you don't know if you're cured. This is the story. So post-treatment Lyme disease syndrome, when they've actually, Hopkins and other studies have looked at PET scans and other scans by mass spectroscopy, metabolics, there was a difference between the PTLDS versus non-PTLDS control. So there's something different in patients who have persistent Lyme disease and the way that it affects the brain. By PET scan, the PTLDS patients, these are the people that are treated and still unwell, showed microglial activation with abnormalities in 8 different brain regions, especially the cerebellum. And a lot of the symptoms that Anne described previously are all triggered from the posterior parts of the brain, the cerebellum. And this is the publication here from Journal of Neuroinflammation. So in those who had the abnormal PET scans, only 50% had a rash, only 50% were antibody positive. These are people with diagnosed Lyme disease, according to Johns Hopkins Lyme Research Center. And they continue to have symptoms consisting of memory change in 58%, difficulty finding words in 58%, difficulty concentrating 75%, cognitive symptoms in 70 and 100%. They did a whole range of surveys, batteries, and there were abnormal test results in fatigue severity score, Pittsburgh sleep quality, short form McGill pain questionnaire, Beck depression inventory to the SF-36, both the physical and the mental component score. So these patients with PTLDS from Lyme disease who had abnormal PETs had lots of problems, which is well documented. And then interesting, just kind of the favorite subject of recent times is how about long COVID? What are the PET findings there? Well, an awful lot of similarities in terms of their findings. And this is a PET scan study of 35 long COVID patients. They had bilateral hypometabolism in the rectal orbital gyrus, affecting the olfactory gyrus, the right occipital lobe, including the amygdala and the hippocampus, extending into the right thalamus, bilateral pons medullary brainstem, bilateral cerebellum. So they had some of the same involvement from long COVID as long Lyme. And their symptoms include hyposmia, anosmia, memory, cognitive impairment, pain, and insomnia. So quite interesting that we're seeing a very similar spectrum of disease. But when they actually try to locate the findings and the symptoms, abnormalities in the right temporal cluster were associated with pain and insomnia. Brainstem cluster was associated with pain and insomnia. Cerebellar cluster was associated with hyposmia, anosmia, memory, cognitive complaints, pain, and insomnia. We've not had the same extensive studies done in Lyme disease because it's not been recognized that chronic Lyme is even a real condition. So lots of studies now coming out on long COVID, very studies on Lyme disease. So let's just talk about Bell's palsy. So Bell's palsy can be caused by multiple different infectious diseases. And here's the important message: latency 3 months to 5 years. Okay, it doesn't have to present right away because it can present many years later. And most people seeing Bell's palsy 5 years from a tick bite wouldn't think to ask the question, did you have a bullseye rash? So this is one of my patients, a 35-year-old woman from Donegal. She had 5 years of trigeminal neuralgia, jaw pain, intermittent weakness in the face, and seen by lots of different people. She had other non-specific symptoms which had developed over the last number of years, including palpitations, fatigue, brain fog, pains all over the body. And this is a telltale sign for me. An isolated Bell's palsy with no other symptoms. Maybe that is viral, maybe it is zoster, but if you've got disseminated disease elsewhere, red flag, this is suspicious for Lyme. She was seen by urology, ENT. She was given pain medicines with really poor relief of symptoms. She herself Googled Lyme disease and asked the GP to test for Lyme disease. Now, in Ireland, just like everywhere else, you ask for a Lyme disease test, you're crazy, you don't need it. You want an HIV test? They'll do an HIV test, and none in Ireland. We have hundreds of thousands of HIV tests being done, and people who don't need it, and we have people refused Lyme tests. But anyway, going back in the history, this patient recalls a rash 7 years before, which was diagnosed as ringworm, treated with topical cream. Donegal is a hotspot for Lyme disease. We've done studies. The patient explained the relationship between Lyme disease and Bell's palsy to the GP, and the GP said, this is Bell's palsy. This is Bell's palsy, not Lyme, and they refused to perform the Lyme test. The patient then accessed a test called the Tick-Borne from Germany. It was positive for Borrelia. It was also positive for anaplasma, which is a second tick-borne infection. So people say the German tests are no good, but Borrelia comes from a tick, anaplasma comes from a tick. Tick-Plex Plus is a biotech company from Finland. The Germans buy the kit, run it in Germany at an accredited laboratory, and we're told we don't accept German tests because they're not validated, they're not accredited. But anyway, it took a long time for her to get to a point where she could even get a Lyme test. And she then was referred to me. I did a series of tests, baseline tests, started her on combination antibiotics, which cover both Borrelia and anaplasma. And when she was seen at 2 months, interesting, her first set of blood showed mild lymphopenia, decreased CD3 cells, increased ferritin, increased muscle enzymes, weakly positive ANA, increased immunoglobulins. Because like I said, this is just not an infectious disease. If it's been going on for years and years, it's almost an inflammatory autoimmune disease. She reported 50% better at this time of all of her symptoms, less jaw pain. And I think the jaw pain was actually kind of a neuralgia coming from the nerve rather than a a TMJ. She had better energy, better cognition. She was given a repeat prescription for combination antibiotics. And when seen 3 months later, she had resolution of all of her symptoms, which had been going on for a period of almost 5 to 7 years. So that's case number one. And I think I see patients with, Bell's palsy or Bell's palsy type symptoms. They don't always have the muscle weakness. They may have, it could affect the nerves. It could present as pain, dental pain, TMJ pain, shooting neuralgias, and sometimes intermittent weakness and muscle pain. But I think you end up seeing a dentist because you've got jaw pain and have your teeth taken out. You end up seeing an ENT doctor and having surgery in your temporomandibular joint. But I think that there's lots of different subtle manifestations of damage to the cranial nerves that Lyme affects, cranial nerves 5 and 7 running through this region, and is very often missed. The next case presentation I want to present is a case that was diagnosed as FND. So this is a 19-year-old Oxford student. He had a history of living in Dundee, Scotland. He was a Duke of Edinburgh Award recipient, i.e. he was outdoors a lot in the barren north of Scotland, where the preponderance of tick-borne infections per population is reported in the UK. And he presented with sudden onset of dizziness, fatigue, weak legs in January of 2021. And I actually saw him a while later, after he had been admitted to a major medical center and had been evaluated and been diagnosed with FND. And I actually had obtained a history that he'd actually had a similar episode 2 years before in the springtime while he was still in Scotland, associated with dizziness, rotatory eye movements, room spinning, loss of sensation in his right legs. His right eye had drooped, but it resolved spontaneously within 5 days. But either way, based on the presentation in January 2021, he was admitted to a university hospital. They worked him up head to toe, did a lumbar puncture, didn't find anything. I think they did a brain scan. Since they couldn't find anything, they diagnosed functional neurological disorder. The family actually were suspicious about Lyme disease, but neurology service refused the family request to do a Lyme test because it couldn't possibly be Lyme. So when he was discharged from the hospital, the community GP outside of the university hospital did a Lyme test, and it was positive by all criteria. Positive Borrelia by ELISA, Western blot, every test known to mankind. So it was IgG positive, IgM negative. So because he'd been given this diagnosis and basically very little recommendation except you'll get better, he was seen in private consultation by me. Based on his history, and we had the test and his symptoms, and his symptoms include poor energy, headaches, poor concentration, right eye pain, and actually had some weakness in the eye, and lots of vestibular symptoms. He was unable to hold his head up. He had a lot of rotatory nystagmus. So I started him in combination antibiotics and saw him 2 months later. So antibiotics, I put him on LDN, I put him in supplements. He had improvements in 2 months. His fatigue, he was walking, his head strength was better, his headaches were gone, his concentration was better, the right eye droop, which I think we talked about. The cranial nerves that are involved with Lyme. It's not just necessarily a Bell's palsy. The right eye droop had totally resolved. His bloods initially had shown a lymphopenia, that was resolved. What had not got better was his ongoing dizziness and the problem with head movement. So I continued him on treatment. An MRI had been performed. I then received access to that result. A well-defined T2 hyperintense focus in the left frontal white matter. So he was seen by multiple different specialists, by the neurologist who had diagnosed FND, who were set in that diagnosis despite subsequently having a Lyme test that was positive, and despite subsequently having a scan that was read as as abnormal. One of the Oxford stroke specialists reported to say it can't be Lyme because he doesn't have shooting pains. So this is the people have a very strong opinion about things. A report from the brain and mind neurology consultants. This is FND with constant vertiginous sensation, which may be due to FND, but would benefit from further assessment. The question is, what further assessment? Further notes from the neurologist. I note when the question of Lyme disease, and they found out that he was actually being treated for Lyme disease, and that he actually had improvement of many, but not all of his symptoms on treatment. I note the question of Lyme disease. This was very thoroughly investigated, and you have IgG positive, IgM negative serologies for Borrelia, kind of implying can't be Lyme disease because despite the fact he's positive, it was an IgG, not an IgM. But an IgM goes negative quite quickly. An IgM for COVID sometimes never goes positive, only IgG positive. So you have to understand how to interpret your serology. And very simply, he could have negative serology and still have Lyme disease. He did have a lumbar puncture done, which was entirely normal. And there was no evidence of Borrelia in the CSF. And then he received 3 weeks course of doxycycline. Bob's your uncle in any case. So he must be cured. Even if it was Lyme disease, which we refuse to entertain, doxycycline cures 100% of people. So the message here is that we have a real reluctance of the specialists to change their mindset in terms of the spectrum of disease for Lyme disease. I interestingly I had a court case of an unfortunate woman who postpartum got CSF herpes meningoencephalitis, and she was managed in the hospital, had lumbar puncture that was perfectly normal, had kind of a frontal lobe abnormality. They put her on every antibiotic known to mankind, but never put her on an antiviral. And if you look at the literature on herpes meningoencephalitis, it doesn't always affect the temporal lobe. The CSF is perfectly normal in 10% of the cases. And this was a misdiagnosis. This woman actually had brain damage because the neurologists actually, were set in their ways that this couldn't be, herpes meningoencephalitis. So they didn't even do the PCR because it didn't meet the criteria. There were no cells present. And sure enough, when she progressed and went into coma and was brain damaged, there was a CT done that showed up evidence of temporal lobe damage. And then, the radiologist suggested, herpes. They went back and got the CSF sample and did a PCR, and it was positive for herpes. So I'm just thinking that there's a spectrum of disease with neuroborreliosis, and we have arbitrary terminology that says you have to have this abnormality, that abnormality. So additional comments, patients had FND, there is every chance he will have complete recovery, and management includes education, physiotherapy, and sometimes CBT. On my recommendation, since he still had significant CNS disease, the question was, would he benefit from IV antibiotics? ID advised another lumbar puncture, which was normal in the first place, to rule out Lyme and look for other causes. They declined the request for IV antibiotics to be administered. And then most importantly, this patient get very little support. He needs vestibular rehab. He needs lots of other support because there is damage to his vestibular system, which needs further support. Now, just Tuesday, I saw a new patient, a 20-year-old student nurse from rural Ireland. During the summer of 2016, this is her summary. I remember a large circular rash on my leg, which I presumed was an insect bite. My dermatologist told me it was not Lyme, because the mother asked if she's rare Lyme, but instead it was a spider bite, not painful, bullseye rash. 2 months later, she began to feel unwell with swollen lymph glands, difficulty choosing, pain in her head, fever, pain in the jaw, trouble with energy and concentration. Lyme test declined or not even entertained. She attended for evaluation because she's worse now, unable to continue her work as a student nurse. Symptoms including extreme exhaustion, poor concentration, brain fog, severe migraines, never had migraines before. Interestingly, extreme anxiety, I thought to include this, anxiety that she'd never had before, calm person all of her life, but sensitive to bright lights, repeated episodes of dizziness, right-sided jaw pain, which I think was kind of a trigeminal neuralgia, kind of almost a palsy. She had her wisdom teeth removed because they thought it was that, no resolution of the pain. She had intermittent sweats, floaters in her eye, migratory muscle and joint pain. She then, 6 years later, because she's getting worse and worse and worse, unable to attend her training as a nurse, went to the GP, requested a Lyme test, which was positive by all standard criteria. So further tests and treatment have been provided me, and I will update you on her outcome in a few months. And my experience is looking at the history, bullseye rash, symptoms 2 months later, jaw pain, wisdom teeth out. I kind of liken the pain that people have in their joints caused by inflammation to what's going on in the brain. And I usually ask my patients, are you having head pressure, head pain, kind of creepy crawlies in your scalp? I think there's kind of cutaneous, neurological involvement, concentration problems, energy problems, sleep disturbances, personality changes. And I ask my patients, do you have any of these? And they just look at me, they drop their jaw, and I say, well, I've had hundreds of patients that present with this, and 50% of the patients I see actually have been given a psychiatric diagnosis because years and years later, they have all these symptoms that don't make sense, and they're going time and time again to the hospital, to the doctor, and people kind of get tired. And I always say, why would a person who previously never attended a doctor in their life all of a sudden attend 10 times in 1 year? Rather than saying to the patient, are you depressed? Is there something wrong, with your family? Sorry, I just, rather than saying to the family, there's nothing wrong with you, do you need psychological support? I think it's much kinder to basically say, we know there's something wrong. We haven't figured out, but we will work with you. What if you miss the diagnosis? Patients become chronically unwell. And I presented a few cases. The nice guidelines say there's no such thing as chronic Lyme, but there's compelling evidence that in studies that have come out over the last number of years that Lyme does persist. And the chronic symptoms that people have, you can argue if they're infectious or post-infectious, but there's clear evidence that from PET scans and others that there's abnormalities in the brain. There's ongoing inflammation. Is it infectious? Is it post-infectious? I think many cases, not every neurological case is going to be Lyme disease, but I think too many times we diagnose people with FND or fibromyalgia and not entertain other possible diagnoses. So the testing for Lyme and co-infections is imperfect. We do not understand the complex interactions of infectious inflammation and autoimmunity. We treat every other disease based on patients respond to therapy. We don't set 3 weeks of treatment. Bob's your uncle, you've had your course. As mentioned before, I treat lots of patients for longer courses of antibiotics. I see some of my colleagues in infectious diseases treating bone infections, which are supposed to be treated for 6 weeks with 6 months of IV outpatient antibiotics. Why? Because in some cases, that's what it takes. We need better research and we need more compassion. The patient is sick, not getting better, we're missing something. Don't blame the patient, question the science and failures of the healthcare system. And we need to listen to patients. Just because we cannot find Lyme with the current testing doesn't mean it isn't there. So thank you.